welcome everybody to this webinar on COVID-19 and the support of remote and vulnerable populations. The next 45 minutes, 60 minutes, we will present a few first-hand experiences with support, even medical support of remote and vulnerable groups. We have three speakers. I will introduce to you very briefly now. Dr. Ritchie. She's a research fellow at the International Institute of Social Studies, Erasmus University. And furthermore, she lives very close to Nairobi and is working intensively with Somali refugee women in a place called Little Mogadishu, also in the neighborhood of Nairobi. She's some first-hand experience with dealing with, informing, keeping in contact with those refugee groups. We have Dr. Pratap Kumar. He is CEO of Health eNet. He's a medical doctor. He developed practical digital tools for tele-medical support, remote and marginalized regions, the corona screening tool, and the web service for tele-consultations. And last but not least, we will hear Mariken Gaanderse. I hope she will join us in a minute, of Upinion. And Upinion launched just recently this week their COVID-19 monitor for refugee populations. All experience, I think, that will help you in these complex times. This webinar started with the questions of our NGO members. I am from KUNO. My name is Peter Heinze, the coordinator of KUNO. KUNO is a platform for humanitarian knowledge exchange in the Netherlands, a consortium of NGOs, academic institutes, and firmly supported by the Ministry of Foreign Affairs. And they came with these kinds of questions. How can we help remote populations on a new, innovative way in this corona crisis period? So this is where we started. We started to search in our network for beautiful examples of how we can help them in a different way, or maybe not even a different way, but on a decent way. The last person I did not introduce is Joanna. She's my colleague, Joanna KUNO, Joanna Kalis from KUNO. She will check the chat box, so please come forward with your questions and please introduce yourselves. Let's start with the first presentations. We have three presentations. The first one is of Ritchie. She is not only a postdoctoral research fellow at the Erasmus University and not only an independent development consultant, but she also is aligned to the Center for Frugal Innovation in Africa, where she's involved in the project Exploring Refugees and ICTs. There's a recent working paper of her. I will share it later if it's okay with Holly. Innovating towards inclusion and integration of fragile environments. This paper looks well into potential transformative roles of ICT solutions and other tools. Now, in many ways, she's very much involved in new solutions and tools. Please, Holly, before you start with your practical solutions from your daily work, and how you make them very valuable, could you please tell a little bit more about the Somali women you are working for? How do they experience the COVID crisis, and do they have the right information? And then after that, the floor is all yours, of course.
Okay, so could I start with just a little tiny background to this current project and the work? So my work and the research I do takes a very special focus on looking at norms, social norms and change in fragile economic development. That is where the state is either absent or unwilling to provide basic services or security. So it's taken me to conflict environments, Afghanistan, and more recently to refugee contexts, including in the Middle East and in East Africa. In my research in refugee contexts, I've looked particularly at also the role of ICTs and how they influence social inclusion, particularly looking at women and integration in urban settings. So outside of camps, but I've also visited refugee camps in this region. So on the back of this research, I actually set up a very small self-funded refugee project just outside of Nairobi in a place called Eastleigh, which is also known as Little Mogadishu, because it's really very much inhabited by Somali refugees. And the project was really designed to promote well-being, economic development, and leadership. And to facilitate coordination in the early stages, which was in 2018. As a kind of trial, I set up a WhatsApp group, but also recognizing at the same time that only about 40% of the women refugees in the group, so there were 25 women, had smartphones. But I was looking to see of whether perhaps they might also have children that had a smartphone, so that would be able to use that number. And in fact, it proved to be a very interesting mode of coordination. So through this WhatsApp group, to reach these women, if not directly, through their children's phones or even their neighbors' phones. And whilst a lot of these women were also illiterate, the tool has proved quite remarkable in coordination through voice messaging, pictures, motivational messages they themselves share and send, and information sharing. So coming to the coronavirus, it's almost taken on a critical new dimension in being able to share clear information about, let's say, health advice about the virus, graphics, and albeit a lot of those messages are in English and the graphics are in English, the children of some of these refugees are able to translate some of the messages. But we can also share government directives. So in Kenya, every single day there's an update that comes through from the government, and it's widely shared through WhatsApp. But of course, if you're a refugee in a marginalized area of the city, you're probably not receiving directly those government directives. So through this, let's say, this sort of social media experience, I'd like to share perhaps a few lessons learned, which are partly from, let's say, some of my background research, but also this direct experience with the Somali women. Firstly, some of these what I call very simple social media tools can be incredibly useful in these marginalized urban settings, in terms of being able to share this information, and also to illiterate groups that can't necessarily read. So you can share it if needs be by a voice message. Part of our project is also that the women, when they receive messages and training, they have to pass it on to at least 3 other women. So whilst at the moment it's difficult to monitor whether they're passing it on, there is a sense that they have their own connections in their apartments that they live, and they're able to share some of these key messages, perhaps digitally, or if not, verbally. These tools, of course, have also proved to be a cheap and effective way of reaching groups that otherwise, if you think about it, you would have to go either door to door. A lot of messages on the streets can be perhaps false. So this is a way to be able to share credible information, which, as I say, might be more reliable than that information they might have got through other means. So even through Facebook, some of the scaremongering about the coronavirus or some of the rumors. But of course, in a sense, there are challenges. You know, at the moment, we're reaching perhaps about 100 women. But, you know, there are maybe 100,000 Somali refugees in that region. So it doesn't come without its challenges. I don't think we've solved everything through it. I think it's one part of a solution to use such tools, but reaching scale at present is still difficult, but I feel like it's a starting point.
Thank you so much, Holly. Holly, some questions for you, because you say you can inform them, even illiterate people, but do they also come with questions to you? Is it one way or is it two-way information?
In fact, very interestingly, when I set it up, I imagined that it would be a one-way direction and that we'd be sharing coordination, some information. This was 2 years ago. And in fact, the group had took on a whole new energy in life by itself. So they share almost on a daily basis motivational messages from the Quran, and particularly at this time when, you know, it isn't just about sharing health messages. People are quite frightened, and so they share themselves sort of spiritual boosting messages, which they do periodically, but perhaps even more so at this time. Questions, in terms of actual questions, a lot of their messages that they share are in Somali. So my Somali coordinator in Eastleigh responds back in Somali. At the moment, I haven't been able to catch up on some of that dialogue. But at least there is absolutely a two-way exchange. And of course, some of the refugees are not, some are more active than others. And I haven't, it's still in its early stages in the sense that I haven't done rigorous research around the extent to which everybody is benefiting from, being able to access the messages. Perhaps if their son has the smartphone in the house, that she isn't able to be on it all of the time. There are all those kind of constraints, which I talk about in this paper on refugees and ICTs, looking more at that, the sort of usage of these devices and who controls the device in the household. But I think, as I mentioned, it is definitely a starting point, to be able to use this kind of technology to reach groups that otherwise were sort of a bit out of the perimeter, if you like, and not able to hear much more than hearsay or what they managed to understand from the papers. So I think that it's definitely a step forward.
Okay, thank you very much. We'll move on to the next speaker, Pratap Kumar. We move from a very well-known and feasible tool like WhatsApp to a rather new and not so well-known yet a tool, I think. And this is where Dr. Pratap Kumar comes in. He is CEO of Health Enet and also based in Nairobi and well involved in the medical support for remote populations, such as the Turkana in Northwest Kenya. I think this presentation might take a little bit more time because he has two tools to explain. I think they're both very useful for remote medical services. But maybe Dr. Kumar, you can start with explaining, you told me how you first started with this teleconsulting. Where did you get the idea to start medical support from a huge distance?
Thank you, Peter. You're forcing me to stay on this screen with a very boring background, but I'm happy to tell you a little bit about my story, which provides context into why I'm doing what I'm doing. So I started off as a medical doctor trained in India, and while I got quite fascinated by medical research, especially in neuroscience, and then I started a PhD program in Switzerland in neuroinformatics. But during this time, I was always getting a lot of questions from friends and family back at home with relatives who have been who are sick, who have had a stroke, who are advised brain surgery, about what to do next, and can I connect them with the top doctors in Switzerland or Germany. And what I saw then was that the supply, the desire to help is there. It's just that the mode of communication, or being able to share information about medical cases and being able to review information and give advice over distance, is very inefficient. And this was the time when Google Health was starting off and trying to make a dent, and Google and Microsoft's efforts have come to a stop in that direction. But that's the motivation of what I'm trying to do now, is to try and make things as efficient as possible. And it starts with information, gathering information at the ground in places like Nairobi or Turkana, and sharing that information effectively, and then making use of that information. And so what I'll show you now is really that effort of how do we make information gathering and sharing as simple as possible, so that the technologies that what Holly was talking about become really accessible without the barriers in terms of use of how do you, what do you download, what do you do, and so on. And so I'm hoping that what I show you as a brief presentation would be able to give you an insight into how we are approaching use of technology in some of the most remote and marginalized areas, and likely relevant now in the times of COVID as well. So, so essentially what I'm doing is sharing my mobile phone screen. Can you see my screen now?
Mm-hmm.
Yes, we see it.
Good. It's not just to show some slides, but I'll give you some more information about this. So let's start with some of the big barriers about how data comes from places like KUNO. So most places like this will rely on paper-based documentation. And the amount of effort involved in supporting getting data out of paper-based records is hugely challenging. And so this is one of the first problems we want to try and impact. But the reality is it's very difficult to put in computer-based systems or very complex software into small facilities in very remote parts. And so what we started to do, and this is data from, these are real records from some of the slum clinics. So I'll just zoom into this particular piece of paper here. And this happens to be a case of hypertension being managed in the slums by a clinical officer in a small, tiny facility. And we have no idea if what she's doing here is evidence-based or what, indeed, what drugs are being prescribed, unless you spend a lot of time trying to do some audits on this, on these sheets of paper. And many of you probably have experience in trying to audit handwritten notes. But instead of that, what we did was to put in a very, come up with an approach of saying, we need to put in some structured data here, and we can't afford to put in computer-based systems to give that structure. What is the simplest way we can, simplest approach to put in some structure into that paper-based record? So this is one of those approaches. So what you see here is the same patient's case sheet 2 months later. When this patient has come in, what the clinical officer has done, or the nurse has done, is put in a rubber stamp into that piece of paper. So it's a simple stamp that allows you to start putting in, just like your multiple choice exams, you can shade a few circles and enter structured data into this piece of paper. And so what I'll show you now is what we think is the next step, or what, from that. So please excuse the phone being, the screen being changed, but what I'm doing is going to my browser. So this is the browser just like any of your, on any phone, right? And I've gone to a particular website that anyone can go to, and I log in. And when I log in, I'm asked 2 bits of information. One is the registration number of this patient. So let's just say I'm going to pick up a test patient for now. And what template, or which of that rubber stamp templates are you working with? I seem to have a few on my phone, but most places have a few. And okay, it's hypertension, this version. And when was the patient seen? The patient was seen today. Let's just leave it like that. And I go forward, and what I get is camera screen. And I'm going to point it on my notebook where I have a similar stamp that you saw on the patient's case sheet before. And I'm going to take a picture of that stamp. And what we see in a couple of seconds is all that data that was entered in that piece of paper has been picked up in electronic format. So all the green circles are the circles that were shaded. And I can change that. So in the center of your screen, I can interact with this screen and say, okay, if there was a mistake there, I'm going to change that to a yes. I'm going to, so now if I'm happy, I just click on that green tick over there on the top. And that has created a medical record that is now syncing to the cloud, and it is synced. And all this information has come in from this picture that I just took. And it has not only gone to the cloud, but we have detailed information about about how, say, hypertension is being managed in multiple facilities, many patients, and lots of detailed information about these cases that can be charted, visualized, analyzed, and so on. And I'm going to ask, I've asked Peter to share a video that we made in response to the COVID. So we have COVID screening tools that can be similarly used with just pieces of paper that can be used by community health workers at different points of screening that generate rich data that we can start doing things with. And what I want to do now, briefly, maybe another 2 or 3 minutes, is to show you what we can do with this kind of information. And that comes to the idea of telemedicine and other ways of impacting patients' lives. So what I'm going to do is go to my text messages, and let me just search for a place called Kerio, which is in a very remote part of Turkana. And these are cases that have come in from there. So I'm just going to say, click on, so this general referral case from Kerio Health Center to Lodwar County Referral Hospital has a link, and this link or this SMS would have gone to a doctor in the Lodwar County Hospital. And what that doctor would do is click on that link on any device, right? It would have gone to him on email as well as an SMS. But as soon as he clicks on that link, we quickly say, okay, this is a case of intestinal obstruction in a 39-year-old male, and this case has been summarized. There's both structured and narrative data. So you can imagine part of the information coming in from a template like in the rubber stamp, but since it's a referral, we want more details about this case because every referral is slightly different. And we use some clinical communication principles like SBAR, situation, background, assessment, and response. It allows nurses to communicate information about this case very quickly. So 4 sentences that allow this case to be shared. So now the doctor in the referral hospital knows what case is coming. If I go to another case here about a consultation case, this is a case of neonatal sepsis. And this case was shared with a doctor in Nairobi, and that report is over here. And that report was shared with the nurse back and with some advice about what to do next. And I'll show you one more case, and just to demonstrate what is possible on this technology. I'm going to search for. So this is just a quick demonstration of the technology that we can implement on simple tools like SMS and browser. So ignore what the case is, but what I'm going to do is click on this video link in the middle, and what that allows a doctor to do is start a video chat like now with the patient who would have clicked a similar link on their SMS, and we can do this without any complex software being installed or instructions and training for people. It's just a simple link on an SMS that fires up pretty sophisticated tools that can be used on almost any device. It works on a laptop with a browser, it works on a phone with a browser, or a tablet with a browser. What I'm going to do is probably stop now, and there's much more we can do in a more interactive format, and can go into more detail if needed. So let me stop sharing now and hand it over back to Peter.
Okay, thank you so much, Pratap Kumar. I think it's fascinating. I try to summarize, but what you basically do is acknowledge that there is very low technical support and that people work paper-based. You offer a stamp, a rubber stamp, and they have to fill in the stamp, can make a picture with the telephone, send it to you, and then you can help with consulting, diagnosing the troubles, and guide the medical staff over there, a nurse or whatever, with their medical support for this particular patient. You don't need very fancy tools or new digital modules or whatever. So I think it's fascinating that how far is this? Is this the first stage, or can you already use these tools, or are they still in process of being made available?
Yeah, really good question. Thank you. So, so these tools have reached the stage of commercialization. So we are essentially selling these tools to whoever wants to use them. So we use them for initially on research-based projects, so we could demonstrate the use and impact of these tools. So our goal, as you know, you will know in the medical community, we need to demonstrate the impact of these tools before we can expect other people to take on these tools and start using them. So we have, for example, demonstrated that we can take simple rubber stamp-based information about what antibiotics are being used in the slums in Nairobi, and feed that information back to the clinicians and say, okay, you're using these antibiotics which are not appropriate for this particular case, whereas these other antibiotics are appropriate and available. So maybe you could make that change. And so we published a paper in the BMJ recently saying that this actually happens. We can take very simple information from very simple tools and have a very powerful impact with that. And the same thing with the telemedicine work. We have another paper coming out soon about how this can be implemented into health systems. And that's kind of our goal, is that we want technology to be as possible to use across the system or sustained in the system. And that's why the innovation is necessary. It's not easy to put in existing tools, which are typically coming from a Western hospital setting, and expect them to work in a case of Turkana. Right? And that's where the innovation is really needed, and rethinking how we can generate and share information for supporting healthcare over here. So the short answer is yes, these tools are available. We are commercially deploying them right now. And so hopefully we'll have more, these can be used as much as possible.
And there are always very big privacy issues. As soon as you put your medical data on the internet or whatever web service, people get very concerned about who has access to this medical data. Is that also something you have taken into account?
So absolutely, we have to, and that's where, as a medical doctor myself, so it's been useful to have that understanding of medicine to be able to develop systems that I think will work for myself and other people around me. And so, but it does involve a lot of thinking around how we can keep this data secure. And it's a balance between what a remote doctor needs to see and what, so for good clinical practices versus what should remain private. And so we do things like, certainly don't share last name, identifiers, date of birth, address, or anything like that. The doctor gets a first name, age, and sex that they can work with. Those links that you saw are every time a case is created or information comes from a tool, for sharing, we make a new database with one single case and share the link to that new database. And we can control access to those links. We know who's accessing that link. Are we expecting this link to be accessed from the Netherlands or from Nairobi? And we can flag access to those links. And once the case is complete, we can retire those links so that disappears from the web. So the system underlying it is not exposed. The doctors will see this case for the period of that particular case, report it. The report is available to the doctor and the patient, but the case disappears from the web. So there's a lot of design around how do we share this information as effectively and safely as possible.
I see there are two questions. Johanna, do you have a good overview over the questions? Then we do two questions for Pratap Kumar, and then we go to Mariken because he's also waiting with her. Johanna, would you like to explain, or shall I repeat the questions?
First, the one on data, because we're already talking about it. The question on the sensitivity of the data. So it's not just about privacy, but also on what happens with the data and could it be manipulated? Or how easily can the tools be used in remote areas, and can they be used offline? And are they used and or supported by governmental organizations as well right now?
Yeah, so let me just take them backwards. We had some good success last year where, so we've been trying to sell to governments, and the biggest challenge with government procurement, governments using this is procurement. And the main thing is, how does a government in a place like Kenya procure a digital tool that is available on a subscription basis? They've never really done this, and they don't have much experience in procuring digital technology for themselves. And so they're very reluctant to do this, but we've had one success. So Migori County is using this in Kenya. It's a very remote part of Kenya. And yes, it works offline because that's one of the fundamental, the first steps in trying to make these technologies work. Yes, the first time you use it, you need to be online, but after that, it works offline. And so, yes, so those are the main intentions of these tools, that they get used by the public sector in as large scale as possible. We still have to support the public sector in being able to procure digital technologies like this, and that's where working with partners become really important. And so we are now working with other NGOs that have good relationships with the public sector, so they can procure our tools, get them used in the public sector at scale. So now the business models around these sales are what we are trying to get as experienced in and make those work for us. And the last thing is about security and manipulation. And so these are ongoing technical challenges, right? So we do all the industry standards of encrypting data on the phone, encrypting data on the server, and the communication in between, similar to what WhatsApp does. And so these are technologies that are available, and we try to be as cognizant as possible of how best to make these data as secure as possible. But it starts with some of the basic practices. So we don't collect data that might be identifiable, that could be shared. So for example, on the rubber stamp or the templates that you see, they don't need to be rubber stamps. They could be a printed sheet of paper. But we don't collect an identifiable data there. So we combine things like the facility ID and their registration number. So those, so it's only the facility that can combine that registration number with the actual patient. So we don't have any way of combining that information to an actual patient. So let's not collect data that we don't need to collect. And when we share data, for example, we ask for a first name and share the first name. So the doctor and everybody in between knows enough information to say, okay, I'm working with a Marianne, or I'm working with Emily today. But we don't know anything more besides the age and the sex. So it's trying to bring in some of these, it's a combination of behavior and practice as well as technology that will make these things as secure as possible.
Thank you, Pratap. Thank you very much. I think we go to the last presentation of today, and afterwards we'll make a quick round to all the speakers again, because I really would like to hear also Holly reflecting on these kinds of innovations. Mariken Gaanderse, the last speaker of this webinar. Upinion, you work for Upinion and launched very recently the COVID-19 monitor. I would really love to hear lots about this monitor, but first maybe you can explain a little bit more about Upinion. I don't think everybody knows about Upinion. I looked at your website, helping NGOs to get in touch with the people they want to help and amplify voices in crisis situations. Please explain.
There you go. That's the pitch, actually. So indeed, my name is Mariken and I work for Upinion. Some people might know me also from other jobs, but I also work for Upinion. And what we do is amplifying voices of people in crisis situations. So our motto is actually, don't talk about us, but talk to us. That's actually key. And what we see happening also now in the COVID is that what happens is that often these type of crises exacerbate existing inequalities, right? And also power dynamics. And there is sometimes even a tendency, and you might recognize it, that especially in emergency situations, there tends to be a little bit of top-down approach if you're not careful. And at the same time, I'm also almost positive that most of you here understand the importance of involving local communities and individuals in your approaches. So that's why we came up with Upinion. And what Upinion does, it is a social enterprise. And what we do is we allow, let's say, conversations with a large amount of people. So so with thousands of people at the same time, you can have a scripted dialogue. So we've built on top of Facebook and WhatsApp, but we also have our own Upinion app and a web chat app, a web chat, I have to say. We build a tool where you can ask people questions, so in a scripted way, but also send relevant and reliable information back immediately. and send referrals back. So, for example, we're now working in Yemen, but also in many locations, also in Lebanon, and on COVID, we ask people like, do you know a local hotline where you can go to in case you are worried whether you have COVID? Yes, no. If people answer no, then immediately they receive the referral or the link to the local hotline. So it's not like you first have to fill in an entire survey and then 2 months later you get some information back. It's instantly. So it is like you using your phone, your Facebook Messenger. It is a chat app in that, a chatbot in that sense. So it's a scripted dialogue. So let's say you have 15 questions that you answer, and then poof, the next one pops up like you're chatting in WhatsApp, and then immediately receive information back. And we build it on top of it, so also to make it secure. Right? We are ISO certified because obviously we don't want to do any digital harm, so it's secure. And another element that's important maybe for some settings is that we also have voice messages. So if in case people are illiterate, we can use voice messages. Then we cannot ask open questions because with voice messages, people have to click on colors. But you can also send images, you can send small videos. It depends a bit on the quality of the connection. And what we then do is the reports that we have are real time. So that's also an added value. So it's not that you have to wait a couple of months before the PhD researchers have finalized the research. It's real time and it's very visual. So we sometimes call it the Harry Potter reports. It's infogram based. So you see the responses come in directly, and that allows us also to be very flexible and to adjust where necessary. So the other day, for example, we had a question, I think it was in Yemen, where we asked women if they were married. And then there was a huge dropout. So people had the fear that maybe it was a sort of dating app, which it obviously wasn't. But then we lowered the question. And then when it was more logic, because then at one point in time you were allowed to receive a certain voucher, health voucher for a specific health services locally, then there was no dropout anymore. And especially now when it's hard to really meet face to face, we know that in most crisis situations, people still have access to Facebook, and even you only have to have 2G. So it works like WhatsApp. When you don't have connectivity, you don't get question. As soon as you have connectivity, bloop, 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 the messages pop up. So that's a bit the way it works. And in that way, you can make sure that you involve local communities and local people who are actually affected in your approach, because that's also lessons learned from Ebola, for example. It's very important to include the local marabouts or the midwives, for example. So one of the questions we often ask now with the COVID monitor is, where do you get your information from? What are your information sources, and with whom are you sharing it? With how many people are you sharing it? To also start a sort of mapping of who are the key people locally with whom maybe then the organizations we work with can connect to engage with their offline activities. So yeah, I can talk for hours, but I prefer, if people have questions, come with the questions, and otherwise I can give you some more examples or tell you a little bit more, because I have enough, but there's a lot of listening, and I prefer if people have questions that I respond to their direct questions.
I already see a question popping in from MSF. Marieke, can you read it also? I can imagine that many organizations want similar questions on Corona.
So absolutely. Yeah. So what we do, good question, Anna. So what we do is at the moment we because not all information is we want to share, obviously, because it's a contract we have currently with on one-on-one with organizations, but we are starting global shared panels, and so some of the information is not sensitive, and if people are okay with it, then we can share that input. So we don't have to ask double or twice the same question. So for example, when you set up a panel, We want to know, for example, in which location people live, or if they're male or female. So these are type of questions that are, so we do work as much as possible. It's aggregated, so the reports we deliver, you cannot direct it back to the person. But so the information doesn't need to be asked twice or double. So in the global shared panels, several organizations can collaborate. So we're currently also in touch with the Ministry of Foreign Affairs now to do that type of global shared panels, because it's also much more efficient and less costly.
Thank you, Mariken. Yeah, this is also two-way, yeah? But I was like, who does have access to your information?
So at the moment, to be very clear, so for example, we work with Cordate or with the AIDS Foundation, then the information that we have is shared with them and not with others. So it's not public reports. We have one on Turkey that's online. But yeah, of course, we don't want to share all the information with everybody. And at the same time, we also ask the beneficiaries whether they are okay with it. And often we stay in touch over time. So it's not a one-off, but you keep in touch for a longer period of time. And then that's why we do often use Facebook Messenger, because that allows us an ID and a point back. And yeah, so that's how we work.
I can imagine that when you are doing assignments for Cordate or MSF or whatever, that you are looking into Yemen and then into Nigeria and then maybe Kenya. But there should be a moment that you can do some meta evaluation and bring together all this information globally and extract some extra information.
Yeah,
is it something you can do?
Yeah, that's something that we can do. But at the moment we have just started, so the first inputs are coming in. But yeah, you can see some of the myths that are popping up. You can see some of the questions that people have. So you can definitely compare. So what we normally do with the regular work of Upinion, it's not always to be compared, because in Kenya, for example, we work with people living with HIV/AIDS. So that's very specific. And then in Lebanon, we work with Syrian refugees. So it's a different population and different panels. But with the COVID, it's easier to compare, and we have absolutely, that's the nice part, because technically it's very sound and it works already for many years. So we can definitely combine and aggregate those data. That's possible. Yeah.
Okay. I see one more question. I think it's for you, Mariken. Respondents. Is there a way you can connect to them?
Yeah. So what we do is we do it in different ways. So sometimes it's we sometimes work with a local organization who have large WhatsApp groups. So then you can have a QR code or a link that you can share in that WhatsApp group. We also have old-fashioned leaflets with QR codes, so with a link. And we use quite a lot of Facebook advertisement, because Facebook is a big company and they have a lot of people that know very well how to target. So we use their advertisement, and as soon as people click on it, and then they are referred to the Upinion app to stay out of Facebook. But it's a way also to connect back to them. And it depends a bit on the objective. So if you want to have, let's say, 1,000 men and 1,000 women, as soon as you have 1,000 men, then if there are more men responding, you can have a different message, like say, okay, thank you, maybe next time we get in touch with you, but for the moment we have sufficient respondents, and you only recruit women. Or if you want a specific location, or for example, when we are focusing on HIV/AIDS, we're only targeting people living with HIV/AIDS. So you can easily, because it's scripted, you can easily segregate your approach and your information. So with people living with HIV/AIDS, you have separate hotlines that you can refer to, or you have different types of services where you can refer to. But it can also be that maybe if people are in different areas, in this area, that's the hospital where you need to go. And in that area, that's the hospital where you can go.
Thank you very much, Mariken. What was your question?
It kind of stems from one of the partners we work with in Kenya, and what they do is recruit mothers of women, pregnant women who are in ANC care into chat groups like what you do. What these rural women do is send messages, everything from can you eat avocados during pregnancy, to where can I go for my birth, to things like I don't feel my baby moving, and I might be bleeding, what do I do next? And so they have to classify these messages very quickly, so that some messages become flagged and you need to take some action on those messages.
Yeah. So
sense of how you do that in your
in Upinion. So so we don't have a chat group as such. So it's not that people are together in a WhatsApp group. It's one-on-one. Like Facebook, you can have a Facebook group and you can have a Facebook Messenger. So it's really one-on-one, but it's a chat bot. So it's scripted. So because it's scripted, we can see from each question the answers. So some of the questions are multiple choice. So then it's easy to make it visual. And some of the questions are open source, or not open source, or open question, I have to say. So there you can follow them. And if there's something very urgent, I mean, we cannot call that person directly, but we can group them. Yeah, that's a possibility. And it also depends on the services the partner we're collaborating with are able to deliver, obviously. But what we try to do is, it's not just simple service, but there needs to be something in it for the people affected themselves, right? So, because otherwise people don't want to stay in touch with us as well. Because each time we ask them, is it okay if we contact you later? And then most of the time they say yes. Yeah.
Thank you, Mariken. Holly is working for the Center for Frugal Innovation in Africa, and you've studied so many innovations, especially for refugees and ICT methods. What do you think when you hear these kinds of examples of innovative ways of helping the vulnerable people? Are there strong elements? Are there maybe hidden risks? I really would like to hear you about it.
Thank you so much. I have a quick question actually for Pratap regarding his health electronic, let's say, health records keeping, analysis, diagnosis. I wondered if you'd considered, I'm sure that it's come up, but going a step further and making an actual app so that the health professionals can actually go in and be able to just fill it all out. And the reason, I know that you've said that it's important to be able to work offline, but perhaps to have an alternative online, and you could also submit offline. Because in Kenya, in fact, it's, Safaricom and some of the other mobile companies here, they are far reaching into the rural areas. And we do actually have quite good internet through internet bundles. And it might cut out the sort of paper part of it, at least for some of those who wanted to immediately be able to insert the information electronically. So just a little bit about apps, etc., and where that's going. And a question for Mariken. As I'm listening, it's so interesting to hear about your tool, if you like, a sort of survey tool, if I understand, a kind of exchange platform. But I wondered how you deal with reaching different groups of respondents that may not have that access to devices and ICTs. For example, older groups that may be less tech savvy, or women that are also less perhaps able to use those devices and be able to interact on those platforms. So basically the question is reaching some groups that may not be using such devices and ICTs.
Thank you, Holly. Pratap first. Are you going nationwide?
That's the plan. So we are working with the Red Cross here to try and see if we can use these tools as widely as possible, because they have a presence all over the country. But to answer Holly's question, so it comes down to a lot of the fundamental challenges in putting technology into a medical environment. And any doctor or healthcare professional who's been forced to use computers and start entering data into computers can tell you it's a very complex process. It needs a lot of training. It's not so easy. And that's one of the main reasons to keep paper involved as much as possible. It's the easiest thing to do. You can, everybody has a piece of paper. Patients come with a little notebook. You can put in a stamp into that or give them a sheet of paper. And it's not only easy to use, but it's really difficult to get rid of paper completely, because everybody wants to have some kind of hard copy evidence there. They're very concerned about removing every type of hard copy evidence and moving all that onto a technological platform that you access by, when you have internet or in computers and so on. And so this approach really allows you to keep paper involved, keep it simple, allow healthcare professionals to practice as they have practiced for decades, but still get the information that you need from that practice. And so there are a number of reasons why we want to shy away from completely digital approaches to data collection and keep paper very much in that loop. And so again, that's another big drive that we are trying to, whether it's in the academic community or even the development community, to say digital is not equal to paperless. So we keep different ways of getting information. And yes, there is a place for direct digital entry into mobile devices, and we merge that as seamlessly as possible.
Thanks.
Mariken, can you follow up?
Yeah, no, good question. So we have multiple approaches. So for example, in Yemen at one point in time, we also used a call center to really target people in a proper way. So that's possible. So if we feel that the connectivity, there's phones, but no, even not 2G, then you can also go for calling with call centers. And what we also notice is that there's quite a lot of device sharing. So when we target people specifically, and when we have something to offer that people find interesting, if it's relevant for them, we also notice that peers are sharing the information amongst each other. So that's the best publicity you can have, right? So, and with the device sharing, what we've done is with sensitive questions, some of the sensitive, more like, for example, with people living with HIV/AIDS, or with another one on sexual abuse, we make sure that the questions disappear from the screen. So to really keep that level of confidentiality, so you cannot scroll back or scroll forward. So yeah, and of course it is not the only tool. So I think it will not. So for example, with children, we are not able to reach them because you have to have consent of their parents, obviously. But yeah, we are noticing that the advantage is you can reach a vast amount of people quite quickly. So thousands of people quite quickly. And that is the added value, I think. So, of course, you will also need your face-to-face conversations, and there's a lot, but it's an extra, it's an added, and especially now, it's almost better than nothing, let's say.
Yeah.
Thank you, Mariken. I go with Johanna if there are any more questions, but I don't think so. Holly, would you like to make a final remark? Because I think we slowly have to go towards the end of this webinar. We've been on talking for almost 1 hour, and I'm sure everybody can tell a lot more about their innovations. Or is it okay like this for you?
I think all I would say is that I think it's a very, in terms of technology and ICTs, it's such a fast moving landscape of the possibilities of reaching marginalized groups, whether it's for information, whether it's for gathering, let's say, their own feedback, or through then remote diagnostics. And I think that from an aid organization, aid groups should really be watching that space, because it's so rapidly changing. And if we're not at the front line of that, then we'll miss some of these innovative tools for supporting these marginalized groups in humanitarian situations. So I think really it's precisely that, just to be right at the forefront to watch that moving space.
Okay, thank you so much, Harley. And thank you also, Pratap and Mariken, for all your contributions. I love to hear it all.